Hi everyone, I'm Dr. Reshma Elizabeth Rajan. And as we all know, the date for the exam of Dental Assistant Surgeon PSC exam has been released. So it is scheduled on 28th November. So today we'll be discussing a few important questions which has been asked for the previous year in the previous year question papers for the subject of periodontics. So firstly, I will be telling which all topics you should focus on. So basically, you have to cover all the topics for the PSC exam, but some topics you have to focus more, which I have highlighted in the red ring in the slide. So firstly, the pediatric dentistry fundamentals, like the chronology and morphology of primary and permanent teeth. In that, knowledge stages of tooth development, morphology of primary teeth, mineralization and eruption of primary teeth. Second comes the preventive dentistry portions. So in that, fluoride and their role, that is systemic fluorides, topical fluorides, fluoride toxicity, pit and fissure sealants, and preventive resin restoration. So this is a heavily tested topic. So multiple questions has been asked in the previous year question papers from pit and fissure sealants and also fluorides. So please focus on these two chapters. Then caries risk assessment, early childhood caries, sugar substitutes, plaque control measures. Then comes growth, development, and occlusion. In that, development of teeth, eruption and shedding of teeth, developmental anomalies of teeth. Then development of occlusion. In that, early mesial shift, late mesial shift, the transient malocclusions, the terminal planes, which terminal plane end up in which malocclusion, the percentages is all you have to focus on. The next topic is psychology, behavior, and behavior guidance. In that, behavior of children in dental setting, factors influencing the behavior, behavior management, pharmacological behavior management, that is sedation and GA, and specific drug dosages like midazolam, the oral root dosage, the intramuscular root dosage. This all you have to focus on. And child psychology theories, Freud, Erikson, Piaget, Pavlov, Skinner, the various theories. Then anxiety and fear, the types of fear in children. So this all you have to focus on. So psychology is also a topic from which multiple questions has been asked in the previous year question papers. So next is the dental caries chapter, in which etiology of dental caries, clinical classification of dental caries, rampant caries, role of diet and nutrition in dental caries, all we have to cover. Then restorative dentistry and endodontics, another important topic to be focused on. In that, pulp therapy, the classification of disease of pulp and periapical tissues, deep caries management, other pulp therapy procedures, especially pulpotomy, its classification, the materials like formocresol, MTA, calcium hydroxide, etc., and crowns in pediatric dentistry. So mainly stainless steel crowns and their complications, fundamentals of cavity preparation in primary teeth. Next comes injuries to teeth, the prevention and management. So the traumatic injuries of teeth and supporting structure, etiology, history taking examination, and also the splinting time periods, management, sports dentistry in children. So this all comes under injuries to teeth. So next is pediatric orthodontics. So in that, space maintainers and retainers, the types, indications, and complications, oral habits, the classification, etiology, management, the appliances used for this, and also the children with special healthcare needs and medical emergencies. In that, cerebral palsy, autism spectrum disorders, cleft lip and management, medical emergencies. These are all important topics to be focused on. Then comes interdisciplinary pediatric dentistry. So in this, the oral surgical concentration and local anesthesia. So in that, mainly the maximum recommended dosages of LA, fundamentals of local anesthetics, use of topical anesthetics, indications and contraindications for the extraction of primary teeth. And in miscellaneous topics, the dental materials, different types of dental materials used in pediatric dentistry, in radiology, fundamentals of imaging techniques, genetic aspects of dental anomalies, antimicrobials and analgesics. So the drug dosages and prescription writing and all, you can actually you should focus on. So mainly in this, you have to focus on fluorides, pit and fissure sealants, the Nora stages, mineralization, eruption, development of occlusion, the psychology chapters, and etiology of dental caries, pulp therapy, especially pulpotomy, crowns in pediatric dentistry, traumatic injuries, especially the splitting timings, space maintenance, retainers, oral habits, dental care for special children with special needs like cerebral palsy, autism spectrum disorders, cleft lip and palate, the percentages, and all surgical consideration in that maximum recommended dosages and all. So next we'll start with the questions. The first question is maximum recommended dose of local anesthesia for children. Lignocaine 2% with epinephrine is. The options given are 6.4 mg per kg, 8.4 mg per kg, 4.4 mg per kg, and 2.4 mg per kg. So, what will be the answer in this? So, this is a basic, straightforward question. So, the answer will be 4.4 mg per kg. So according to the new AAPD guidelines, the maximum dose with or without epinephrine is 4.4 mg per kg according to the body weight. But in Malamed and also by other manufacturers, the maximum dose of LA without epinephrine is 4.4 and with LAs with epinephrine is 7 mg per kg. So according to new AAPD guidelines, 4.4 mg per kg is the uh, maximum recommended dose with or without epinephrine. So you can opt for option C. The next question is broadband phenomenon is a normal feature in pretended stage, carious lesion in an unerupted tooth, presence of multiple supernumerary teeth, transient malocclusion. So we know broadband phenomenon by hearing the term itself. It is actually ugly duckling stage, which is a self-correcting anomaly or a transient malocclusion. So the correct answer will be D, which is transient malocclusion. So this broadband phenomenon, which is known as ugly duckling stage, was first described by H. Broadbent in 1937. Do see the do remember the person who has invented the ugly duckling stage, H. Broadbent, because it has also been asked as a question in the previous year question paper. So it was seen at 8 to 11 years of age. This is also called Broadbent phenomenon, self-correction. So this self-correct, it's correct. It's a transient malocclusion which gets corrected when the permanent maxillary canines completely erupts. The clinical consideration is during this stage, the children will tend to look ugly because there will be spacing between the maxillary central incisors and there will be winging of the centrals and laterals. So the parents will be often apprehensive because the child will not be having a aesthetic appearance. So they do consult the dentist. So we have to console the parents or reassure the parents that it will get corrected by itself and when the pressure is transferred from the roots to coronal area. So there is no need of any orthodontic treatment. So we have to reassure the parent that there is no need of any orthodontic treatment for this condition. So this is basically how the ugly duckling stage happens. The pressure from the erupting canines get transferred to the roots of the lateral incisors, which in turn get transferred to the roots of maxillary central incisors, and the gap between the space happens between the maxillary central incisors, which gets corrected when the permanent canine erupts into occlusion. So this is Broadbent phenomenon, which was given by H. Broadbent. Next question is the apex of the periodontic treatment triangle is occupied by. The options are periodontist, parent, child, society. So periodontic treatment triangle, by hearing the term itself, you should think that, you should actually remember that it's periodontic treatment. Who is the focus of treatment in pediatric dentistry? It is the child. So child will be always at the apex of the periodontic treatment triangle. So this was periodontic treatment triangle was described by Dr. G. Z. Wright in 1975. This shows the relationship between the child, parent, and the dentist. So child is placed at the apex of the triangle as he is the focus of the attention for the both the dentist and also the family, the parents. So he is placed at the apex of the triangle, and parents and dentist are placed at the base of the triangle. So all these are three are interrelated, which is denoted by arrows, showing that the communication is reciprocal between all these three factors. So the modifications to this periodontic treatment triangle, the first modification was given by McDonald et al. In 2004. So what he added to this periodontic treatment triangle was society, which was added to the center of the periodontic treatment triangle, because society has a strong influence on the overall development of the child, and also the treatment modalities that we do has a strong influence from the society. So society was added to the center of the triangle. Next modification was given by Vivek P. et al. In 2012. So he proposed a new model based on the periodic treatment triangle, and he termed it as pediatric dentistry treatment model. So in the earlier it was a periodontic treatment triangle. So in this, it became a square. So who all was added in the pediatric dentistry treatment model? We had pediatric dentist, society, child, parents in the earlier modification. So in this modification, he added pediatrician also to the treatment model. So it became a square with child at the center. So we have pediatric dentistry, society, pediatrician, and parents with child at the center in the pediatric dentistry treatment model given by Vivek P. et al. In 2012. So why did he add pediatrician to the treatment model? Because pediatrician is the one who first sees a patient or a child when he's having a fever, or he is the one who first refers the child to a dentist. And also in systemic conditions, he is the one who will refer the physician's consent. We refer for the physician consent. So, so for the physicians, someone is actually talking on the chat. Can you please mute yourself? Yeah, thank you. So pediatrician is the first one who refers the child to the pediatric dentist. And also he is the one who, for the physician consent and all in systemic conditions, we need their consent. So it is an interrelated thing when it comes to a child. So we have added pediatrician to the treatment model. So the next is the variations of periodontics treatment triangle. So that happens when the parent is an authoritative parent or a neglecting parent. So there are two major types of attitudes of a parent. One it can be an authoritative parent. So in that case, the periodontic treatment triangle becomes an isosceles triangle. So isosceles triangle means in an authoritative parent case, the parent will be the one who will be communicating more with the dentist. He'll be least concerned about the child's opinion, and he'll always interfere in the treatment and always interfere with his opinions about the child's treatment. The child won't be having any say in that. So in that case, the equilateral triangle now becomes an isosceles triangle. So isosceles triangles mean these two angles will be equal. So the communication happens between the parent and the dentist only, not with the child. So the next case is of a neglecting parent. So in that case, if the parent is negligent, what happens? Still, it becomes a two-way communication. The child and the dentist only communicates. The parent will not be interested in the treatment of the child, or he won't be answering to the questions that we will be asking to the parent. So his communication won't be reciprocal. So in that case, it becomes a right angle triangle. The communication happens more between the child and the dentist. So these are the modifications of the periodontic treatment triangle. So next question is relative analgesia is. The options are conscious sedation technique, use of siblings for behavior management, pre-appointment behavior modification, NSAID prescribed in children. So the answer is relative analgesia is another term for conscious sedation technique. So what is conscious sedation or relative analgesia? So it is a medically controlled state of depressed consciousness that allows the protective reflexes to be maintained. retains the patient's ability to maintain patent airway independently and continuously, and permits an appropriate response by the patient to physical stimulation or verbal command. This was given by American Dental Association in 2016. So 1993 definition, which is used more often as a minimally depressed level of consciousness that retains the patient's ability. The one which is highlighted is the most important part. It retains the patient's ability to maintain an airway independently. So the patient can maintain the airway independently without anyone else's support. And they can respond appropriately on physical stimulation and verbal commands. So they also respond to a verbal commands and physical stimulation. So that is called as a conscious sedation. The patient will be conscious. He won't be he will be conscious, but it will be a minimally depressed level of consciousness, and he can retain his ability to maintain an airway independently, and he will be responding to the verbal commands. So the objectives given by Bennett in 1978 is the patient's mood should be altered, patient should be conscious, respond to the verbal stimuli, patient should be cooperative, and all protective reflexes should be intact. Vital signs should be stable and normal. Child's pain threshold should be in this. Amnesia should occur. So that is why conscious sedation is actually considered to be a safe method, because all protective reflexes are intact in that case, and the vital signs are stable and normal, and also the patient can maintain their airway independently. So that's why it is considered as a safe option in dentistry. Now, given by the objectives given by AAPD in 2022, that is reduce or eliminate anxiety, reduce untoward movement and reaction to dental treatment, enhance the communication and patient cooperation, raise the pain reaction threshold, increase tolerance for longer appointments, aid in treatment of mentally or physically disabled or medically compromised patient, reduce the gagging, potentiate the effect of sedatives. So these are the objectives given by AAPD. So what are the indications in case of a patient who has a lack of psychological or emotional maturity? We can use conscious sedation. Medical, physical, cognitive disability, fearful, highly anxious patient we can use. A patient whose gag reflex interferes with dental care, a cooperative child undergoing a lengthy dental procedure, certain patients with special healthcare needs, a patient for whom profound local anesthesia cannot be obtained. So in all these cases, we can give conscious sedation. Now, what are the contraindications that can happen in conscious sedation? So patients in the ASA stats of 3 and 4, children with special needs, children with anatomic airway abnormalities, COPDs, moderate to severe tonsillar hypertrophy, because why upper respiratory tract infections and tonsillar hypertrophy is considered as a contraindication, because we are giving the conscious sedation through a mask. So the patient has to inhale. So if the patient is having an upper respiratory tract infection, the gas won't go inside the patient's body. So that's why it is a contraindication. Recent middle ear disturbance or surgery, cobalamin deficiency, treatment with bleomycin sulfate. So these are all the cases which are contraindications for conscious sedation. So the characteristics characteristics of a conscious sedation is that patient will remain awake. They will be responsive to stimuli. They will be responsive to sensation of pain. If the patient does happen to doze off, we can easily awake them. And the patient's protective reflexes will be functional. And the patient's cognitive may be modestly impaired. So he'll be having a delayed response to what we are asking or what we are telling. So these are all the characteristics which are there for conscious sedation. So next question is, a 3-year-old child has a fever followed by sore throat, dysphagia, and upper respiratory tract infection. The child soon exhibits small vesicles which rupture to form crops of ulcers of 2 to 4 mm in diameter on anterior facial pillars, hard and soft palate, buccal mucosa and tongue, etc. So the most probable diagnosis for this case will be, so if you see the symptoms itself, it's a typical symptom of a herpes or herpes infection. So this is caused by Coxsackie group A viruses. It affects old children and adults and also seen in young children. The clinical presentation, short duration and manifestations are usually mild, and it will start with numerous small vesicles which will proceed to become small ulcers that contain a gray base with inflammatory border. And the ulcers also will appear on the anterior facial pillar as described in the question, hard or soft palate, posterior pharyngeal wall, buccal mucosa or tongue, and usually heal within 2 days to a week. So this is a typical representation of herpes angina. So next question is intra-application of APF gel. The quantity of gel taken for an application is 2/3 the trough area of tray, 1/3 of trough area of tray, fill tray completely, less than 1/3 of tray. So in case of the APF gel application, we have to take 1/3 of trough area of tray. Why? We will be explaining in the next slides. So acylated phosphate fluoride as a topical agent was given by BB in 1947. So he reported that pH of the sodium fluoride solution was lower. Fluoride was absorbed into the enamel more effectively. So, and Brudewold and his co-workers did systematic investigation and found out that an optimal fluoride acid solution that provides maximal fluoride deposition while causing minimal demineralization. So that was acylated phosphate fluoride. So how do we prepare? It is prepared by dissolving 20 gram of sodium fluoride in 1 liter of 0.1 molar phosphoric acid. And to this 50% hydrofluoride acid is added to adjust the pH at 3 and fluoride concentration at 1.23%. So this is the method of preparation, the technical aspect. So next comes the mechanism of action. So when APF is applied onto the tooth, it will lead to dehydration and shrinkage in volume of the hydroxyapatite crystals. So there becomes a intermediate product is formed in the process, that is dicalcium phosphate dehydrate. So this dicalcium phosphate dehydrate is highly reactive with fluoride and it forms fluorapatite. And the amount and depth of the fluoride deposited in the as fluorapatite will depend upon the amount of DCPD that is getting formed. So as the DCPDs get formed into fluorapatite, deeper penetration and continuous supply of fluoride is required. So because of that itself, APF is applied every 30 seconds and the teeth has to be kept dry for has to be kept wet for 4 minutes. So this is the mechanism of action. Now why 1/3 of tray? So after thorough prophylaxis, teeth will be isolated. For application of gel, patient will be positioned upright and we have to place enough gel to fill 1/3 the trough area of the tray. So that is sufficient to cover dental arches. So that is the method. Why 1/3? Because this prevents the overflowing and ingestion of the fluoride by the child. And also it ensures the sufficient coverage of teeth surfaces, and filling the tray excessively will lead to toxicity and excessive ingestion. So we will fill only up to 1/3 of the trough area of tray. So we will play after that. We will place the loaded tray over the arch and squeeze the buccal and lingual surfaces so that the gel forces in between them, and we'll have to allow the tray to remain there for 40 minutes. So the patient has to be instructed to immediately avoid drinking and eating for the next 30 minutes. And the recommended application period is semi-annual. So that is about APF. So the next question is, midazolam dose in children through IM is 0.5 to 0.75 mg per kg, 0.25 to 0.5 mg per kg, 0.1 to 0.15 mg per kg, 1 to 2.5 mg per kg. So the options are a bit confusing because they have given the oral route concentration also as a right option, but they have asked IM route dosage. So we have to answer it as option C, that is 0.1 to 0.15 mg per kg. So the dosages are oral is 0.25 to 1, IM is 0.1 to 0.15, and syrup is 2 mg per ml, injectable is 1 mg per ml and 5 mg per ml vials. So next question is, stage 1 of the Nola stages of tooth development denotes absence of crypt, presence of crypt, initial calcification, crown completion. So the correct answer is absence of crypt. Nola stage 1 is absence of crypt. So to answer this, you should know what are all the Nola stages. So stage 0 is absence of crypt. Stage 1 is presence of crypt. Sorry, so stage 1 was actually presence of crypt. The correct answer is actually B. I have marked it as answer A. A, absence of crypt, but it has been asked stage 1. So the answer is presence of crypt. So please note that the answer stage 1 is actually presence of crypt. So stage 0 is absence of crypt. Stage 1 is presence of crypt. Stage 2 is initial calcification. Stage 3 will be 1/3 crown completed. Stage 4 is 2/3 crown completed. Stage 5 is crown almost completed. Stage 6 is crown completed. Stage 7 will be 1/3 root completed. Stage 8 is 2/3 root completed. Stage 9 is root completed. The apex will be open. And stage 10 is apical foramen closed. That is, root is completely formed. So just remember that the stage 6 is crown completed. And before 3, it will be absence of crypt, presence of crypt, and initial calcification. And after 3, only the crown starts forming. So 1/3 crown completed, 2/3 crown completed, crown almost completed, and stage 6 will be crown completed. So after 6, it will be about root. So 1/3 root, 2/3 root, root completed, and root almost completed, that is apex open, and stage 10 will be apical foramen closed, that is root is completely formed. So stage 1 is presence of crypt. So next question is Porter appliance is used for posterior bite correction, anterior cross bite correction, midline diastema closure, open bite. So the answer will be anterior cross bite correction. So this is the answer will be posterior cross bite correction, because this is associated with thumb sucking, which results in posterior cross bites. So the appliance will be cemented during active treatment. So this can be used as an appliance for thumb sucking and also for posterior crossbite correction. So we have to activate the appliance by slightly opening the palatal loop with a corresponding adjustment in the molar loop area. And the appliance activation intraorally or extraorally can be done, and it can be expanded approximately 1 mm per side per month, and activated every 3 to 4 weeks until the crossbite is slightly overcorrected. And the retainer can be used for additional 3 months. So next question is enamel formation of all deciduous teeth is usually completed by. So we have options as 3 months, 6 months, 9 months, and 12 months. So the answer will be 12 months. So the hard tissue formation will start at 4 months. By 6 months, hard tissue formation of all the primary teeth would start. And enamel formation of all the primary teeth will be completed by 11 months. That is, maxillary second molar also will be completed by 11 months. And eruption of primary teeth will be starting by 6 months after birth. And by 24 months of age, all primary teeth will be erupted in the oral cavity. So by 2 years, all primary teeth will be erupted. So generally, the mandibular teeth will erupt earlier than the maxillary teeth, and the root formation of primary teeth is usually completed by 10 to 23 months after their eruption. So the least is taken for the incisors and the longest is taken for the canines for root completion. So this is a chart that depicts the hard tissue formation, amount of enamel formed at birth, enamel completed, eruption, and root completed. So if you see, enamel is completed at 11 months. Second molar enamel completed is at 11 months. So we have the option as 12 months, which we have to which you have to opt. So sequence of eruption is in primary teeth is actually A, B, D, C, E. So sequence of calcification is A, B, C, D, E. So sequence of eruption in primary teeth, maxillary, and mandibular is A, B, D, C, E. So next question is, all of the following physical restraints are used to control extremities except postage straps, Velcro straps, towel and tape, triangular sheet. So the answer will be triangular sheet. So for controlling extremities, we have postage straps, Velcro straps, towel and tape, and extra assistant. So this has to be used like fast. We have to fasten the arms of the dental chair and allow limited movement. Frequently prevents overreaction by resistant or competitive patients. Combative patients, and it's helpful for an athetoid spastic cerebral palsy patient who tries desperately but without success to control body movement. So in that cases, we can use all this postage straps, Velcro straps, and towel and tape and extra assistant. So this triangular sheet is actually used to control the body. So triangular sheet is described as a technique to control an extremely resistant child. So this allows the patient to sit upright during the radiographic examination. But the disadvantages include frequent need for strap to maintain the patient's position in the chair, difficulty of its use on small patients, and the possibility of airway impingement, hyperthermia, need for constant supervision. So these are all the disadvantages. So other methods are papoose board, pedi wrap, which is used to control the whole body. So the next question is, the requisites of an efficient Pitta Fisher sealant are all but one. So the options given are low viscosity, resistance to wear, cheliostatic action, and prolonged curing time. So in this, the answer is actually prolonged curing time. All other except prolonged curing time are requisites of an efficient Pitta Fisher sealant. So Broad in 1978 had given requirements for Pitta Fisher sealants. So the viscosity allowing penetration into deep and narrow fissures even in maxillary teeth, adequate working time, rapid cure, good and prolonged adhesion to enamel, resistance to wear, minimum irritation to tissues, cheliostatic action. These are all the requirements for a Pitta Fisher sealant. So the next question is, Durafat fluoride varnish contains fluoride in the concentration of 7,000 ppm, 5,000 ppm, 22,600 ppm, 11,300 ppm. So the answer for Durafat fluoride varnish concentration of fluoride will be 22,600 ppm. So it is also a basic, straightforward question, but you shouldn't confuse it with 7,000 ppm, which is another fluoride varnish concentration, which is available in the market. So Durafat is a sodium fluoride varnish, which contains 22.6 mg fluoride per ml, suspended in an alcoholic solution of natural organic varnishes. And it's available in bottles of 30 ml suspension containing 50 mg sodium fluoride per mg, and the active fluoride available is 22,600 ppm. So next, another fluoride varnish which is available in the market is Fluor Protector. So these are the two main varnishes. So Fluor Protector is a colorless polyurethane lacquer dissolved in chloroform and dispensed in 1 ml ampules. And the fluoride compound is actually difluorosilane, which is present in this. And the fluoride content in Fluor Protector is 0.7% by weight, and the active fluoride available is 7,000 ppm. So you shouldn't confuse among the options. For Fluor Protector, the available active fluoride is 7,000 ppm, but for Durafat, it is 22,600 ppm. So this fluoride concentration is being asked in the question. So the technique of varnish application is, after prophylaxis, the teeth are dried, and we shouldn't isolate it with cotton rolls, as the varnish is sticky, so it can stick on with the cotton. And a total of 0.3 to 0.5 ml varnish is required to cover the full dentition, and the application is done on lower arch because of the presence of saliva. And then on the upper arch with the help of single tufted small brush with the proximal surfaces. And after the application, patient is made to sit with mouth open for 4 minutes before spitting. So the post-care instructions are almost similar to that of the fluoride gel applications. Then which material is not indicated as a root canal obstructing material after pulpectomy in a primary tooth? So to answer this, you should know what all are the materials that can be used for a pulpectomy. So options given here is zinc oxide eugenol, which is used in pulpectomy, iodoform paste, again used in pulpectomy, endoflast, used in pulpectomy. Next is mineral trioxide aggregate. This is mainly used in pulpotomy as to create a barrier, or in cases of remineralization or apexogenesis, we use mineral trioxide aggregate. So the answer will be mineral trioxide aggregate. So the materials used are zinc oxide eugenol, calcium hydroxide, iodoform, Vitapex, walk-off paste, KRA paste, and endoflast. So next question is, during a complex tongue thrust swallow, there is no contraction of temporal muscle, mentalis muscle, lips, facial muscles. So the answer will be temporal muscle. So there are many types of classifications which was given by moire for swallowing patterns. So that, in a normal infantile swallow, in this infantile swallow, the tongue lies between the gum pad and the mandible will be stabilized by the contraction of the facial muscles, especially the buccinator. So when the buccal teeth of the primary dentition erupts, this type of pattern, this normal infantile swallow will disappear. So in this case, the tongue will lie between the gum pads and the mandible will be stabilized by the facial muscles, that is especially the buccinator. Then comes the transitional swallow, that is like transition between the primary dentition and early mixed dentition. So that is a mixing of normal infantile swallow with the mature swallow. So and then comes the normal mature swallow. So in this, very little lip and cheek activity will be involved, and mainly there will be contraction of the mandibular elevators. Then comes the simple tongue thrust swallow. So in this, there will be contraction of lips, mentalis muscle and mandibular elevators, and tongue protrudes into an open bite. That is a definite beginning and ending. Next comes the complex tongue thrust swallow. So in this, it is actually known as a teeth apart swallow. So there will be marked contractions of the lip, facial and mentalis muscle, but absence of temporal muscle contraction during swallow. An anterior swallow and anterior open bite will also be present. So that is a question which has been asked. During complex tongue thrust swallow, there is no contraction of the temporal muscle. And the features are proclination of anterior teeth, bimaxillary protrusion, teeth apart swallow, absence of temporal muscle constriction, and also they will have a contraction of the lip, facial and mentalis muscle. Occlusion of the tooth will be poor, posterior open bite and posterior cross bite can be seen. So next question is preservation pulpotomy is, the options are MTA pulpotomy, calcium hydroxide pulpotomy, formocresol pulpotomy, ferric sulfate pulpotomy. So here is when you should remember the classification of pulpotomy. There are three major classifications which is given in the classification of pulpotomy. So if you know about the devitalization, preservation, what are all the options in that, what are all the materials used in that, you can answer this question. So the answer is actually ferric sulfate pulpotomy. So the classification of pulpotomy, there is devitalization, preservation, regenerations, and also then comes the non-vital pulpotomy. So there is vital pulpotomy, which devitalization, preservation, and regeneration comes. In devitalization, single sitting and two stages are there. Single sitting, it is formocresol, electrosurgery, and laser. Two stages are gysitriopase, E6 formaldehyde, paraform devitalizing paste. In preservation, it is minimal devitalization. So in that, it comes, that materials are zinc oxide eugenol, glutaraldehyde, and ferric sulfate. And in regeneration, the materials are calcium hydroxide, bone morphogenic protein, MTA, enriched collagen, freeze-dried bone, and osteogenic protein. So these are all the materials that come under vital pulpotomy. So the major classification under vital pulpotomy is devitalization, preservation, regeneration. So here we have been asked what is preservation pulpotomy. So we'll be giving ferric sulfate as the answer. Then comes non-vital pulpotomy, in which mortal pulpotomy is given. So the materials are beechwood cresol and formocresol. So try to remember the classification because these type of questions has been asked multiple times in the previous year question paper. So next question is fixed space maintainer used where deciduous second molar is prematurely extracted prior to eruption of permanent first molar is. The option is bandan lobe, distal shoe, lingual arch, transpalatal arch. So the only space maintainer we use when a primary second molar is extracted, prematurely extracted, is actually distal shoe. So distal surface of the second primary molar is actually a guide for the unerupted first permanent molar. So when the second primary molar is extracted prior to the eruption of first permanent molar, we have to give a guide for the permanent molar to erupt. So in that case, we can give a intraalveolar appliance or distal shoe, which provides the control of the path of eruption of the unerupted tooth and prevents undesirable mesial migration. So the indications are premature loss or extraction of the second primary molar prior to the eruption of first permanent molar, advanced root resorption and periapical bone destruction of the second primary molar, A primary second molar with advanced caries that is not restorable, ectopic eruption of the permanent first molar, ankylosis of the primary second molar. So these are all the indications of distal shoe. Contraindications: inadequate abutment due to multiple loss of teeth, poor patient or parental cooperation, missing permanent first molar, systemic diseases that affect healing, cardiac anomalies. These are all the contraindications where we shouldn't give a intraocular appliance or distal shoe. So next question is, corresponding to fluid stage, initiative versus guilt will be similar to phallic, latency, genital, fidelity. So the correct answer is actually phallic stage. So remember this chart. So corresponding to oral stage of fluid, the erection stage will be trust versus mistrust. The anal, it will be autonomy versus shame or doubt. For phallic, it will be initiative versus guilt. So the question here was initiative versus guilt. So the answer will be phallic stage. For latency, it will be industry versus inferiority. And for genital, it will be identity versus false confusion. So the next question is, chalking off effect of enamel is seen after handover mouth exercise, after sodium fluoride application, after traumatic dental injury in a young permanent tooth with a deep dental caries lesion. So chalking off effect is actually seen after sodium fluoride application. So what is the mechanism of action? Let's see. So when sodium fluoride is applied topically, that will react with the hydroxyapatite crystals, and then calcium fluoride is formed, which is a dominant product of reaction. So this actually forms a thick layer. The calcium fluoride, when it forms a thick layer once formed, and it interferes with the further diffusion of the fluoride. So this is called the chalking off effect. So the calcium fluoride interferes with the further diffusion of fluoride from the topical fluoride solution to react with hydroxyapatite. So for this reason, we have to apply sodium fluoride after applying sodium fluoride, we have to leave it to dry for 4 minutes and then reapply. So this is a chalking off effect. So when the sodium fluoride is applied onto the teeth, calcium fluoride gets formed, which will prevent further diffusion of the fluoride from the topical fluoride. That is known as chalking off effect. So the calcium fluoride then react with the hydroxyapatite to form the fluoridated hydroxyapatite, which increases the concentration of surface fluoride, which makes the tooth structure more stable, less susceptible to dissolution by acids, interferes with plaque metabolism, and helps in demineralization of the initial decalcified area. So initially it gives a chalking off effect. After that, it will react with the hydroxyapatite to form a fluoridated hydroxyapatite. So the method of application of sodium fluoride is actually Knudsen's technique. It is known as Knudsen's technique. So we have to clean and polish the tooth and should be isolated with cotton. And sodium fluoride will be applied using cotton applicators, and we have to permit to dry on the tree for about 4 minutes because we have the chalking off effect. After that, we have to repeat the procedure for remaining quadrants, and the patient is instructed to avoid shrinking for 30 minutes, and we have to do it at 3, 7, 11, and 13 years. So next is, which is not a complication associated with stainless steel crown. The options are crown tilt, inhalation or ingestion in the proximal ledge, premature contacts, well tolerated by child. So by seeing the options itself, we can say that it's actually premature contacts well tolerated by child because it's not a complication. So if the premature contacts are well tolerated, it is not considered a problem. So the complications that are usually associated with stainless steel crowns are crown tilt, interproximal ledge, poor margins, overextension of the crown, ingestion or inhalation of the crown, obstructed airway in children. So the other options which were given in this question were crown tilt. So this happens when there is destruction of complete lingual or buccal wall by the caries, or we are doing an over instrumentation which results the crown tilting towards the deficient side. So this may result in finished crown tilting towards the deficient side and placement of an amalgam alloy or GIC prior to when we have to do the core buildup before doing a crown in such cases to prevent a crown tilt. And the clinical significance of crown tilting is minimal unless it occurs on young permanent molars, and whereas where supraeruption of opponent tooth may occur. So next Next complication is interproximal ledge. So ledge is produced. When is a ledge produced? It is produced when our angulation of the tapered fissure burr is incorrect. When we are doing the proximal preparation, if we are not angulating the burr according to the long axis of the tooth, there can be a ledge formation. And failure to remove this ledge will result in difficulty in seating the crown. And especially in cases when the adjacent tooth is partially erupted and the contact is poorly established, when we prepare the interproximal size, it is very difficult to prepare, and to clear the contact area, we have to go subgingivally, which may result in ledge or damage the adjacent tooth. So in that cases, it is advised to delay the crowning until there is permanent, until the contacts are properly established. That is, until the tooth erupts into the oral cavity, we have to delay the crowning. And ledge can also be avoided by extending the slides subgingivally by holding the thin tapered burr parallel to the long axis of the tooth and carefully evaluating the explorer before crown placement. A knife edge finish line is advised in primary than shoulder. So next is ingestion or inhalation of crown. So this is a very common, not common, it's very very complicated thing in while doing a crown procedure, or while doing extraction, or while doing a space maintenance. Also, this is a complication that can happen in case of all this crown space maintenance and while extraction, mainly because we are doing it in a kit. The kit can be uncooperative, so there can be accidental ingestion or inhalation of the appliances. So accidental ingestion of crown can occur due to uncooperative behavior of the child or negligence from the dentist. So how can we reduce or prevent the ingestion of crown, an accidental inhalation or ingestion of crown is rubber dam isolation can be given. Then throat pack with ghost piece. That can be the easiest way to prevent inhalation. We can put a throat pack or ghost piece while placing the crowns or seating the crowns. Then floor attachment by means of impression compound can also be done. The crucial surface of the crown, we can tie a floor so attached using a impression compound. And now crowns with guards have also been invented for preventing this ingestion or inhalation of the crown. So these are all the methods how we can prevent ingestion. So these are all the other complications of stainless steel crowns. So next question is, full strength Buckley's formula solution has a formaldehyde concentration of. The options are 15%, 35%, 31%, and 19%. So the correct answer will be 19%. So if you look at the options, we have 35%. If you answer without thinking or without reading the question, you'll be answering 35%, because that is the most thing we remember about the composition of Buckley's formocresol, 35%. But here they have asked about formaldehyde. So the answer will be 19%. So the composition of formocresol in Buckley's formula, cresol will be 35%, glycerol will be 15%, formaldehyde will be 19%, water is 31%. So preparation, we use a 1/5 concentration of Buckley's formula. So we have to dilute 3 parts of glycerin with 1 part of 30 ml diluted sterile water, then add 1 part of formocresol to the 4 parts diluent, and then add 30 ml for formocresol to 120 ml of this to obtain 150 ml of the dilute formocresol. So this is how we prepare Buckley's formocresol. And the mechanism of action, it prevents tissue autolysis by bonding to the proteins. This bonding is of peptide groups of side chain amino acids and is a reversible process accomplished without changing the basic structure of the protein molecule. So this is a basic mechanism of action of formocresol. So next question is, the recommended splitting period for managing an owl's permanent tooth which has been replanted within first 2 hours and with minimal distortion of alveolar bone. So in this case, the replantation occurred within first 2 hours, and also there is minimal distortion of the alveolar bone. The option given is 4 weeks, 1 to 2 weeks, 6 weeks, 3 to 4 weeks. So according to the normal splitting time, the answer will be 1 to 2 weeks, because it is having minimal distortion of valvular bond. There is no severe distraction, and it is replanted within first 2 hours. So the normal splinting time is 1 to 2 weeks. So according to the IADT guidelines, that is International Association of Dental Traumatology guidelines, this is considered as a best practice to maintain the reposition tooth in the correct position, provide the patient comfort and improve function. So current evidence supports short-term flexible splints for splinting the replanted teeth. And studies also have shown that periodontal and pulpal healing will be promoted if the replanted tooth is given a chance for slight motion and is not splinted for too long. And the splint should be placed on the, in case of maxillary teeth, it should be on the buccal surfaces, and so that we can give a when we are doing the endodontic treatment, we can get the lingual access. And also the replanted permanent teeth should be splinted up to 2 weeks. And the patient instructions that should be given for the patient is follow-up visits should be done, and both parents and guardians of the young patient should be advised regarding care for the replanted tooth, avoid participation in contact sports, soft diet for up to 2 weeks, and thereafter normal function, brush teeth with a soft toothbrush, use a chlorhexidine mouth rinse twice a day for 1 week. These are all the care instructions we can give the patient. The next question is the fear present within the individual that is not due to any stimulus or previous experience is. The options are subjective fear, objective fear, innate fear, none of this. So the fear that is present not due to any stimulus or previous experience is actually innate fear. So the types of fear are innate fear, that is without stimuli or previous experience; subjective fear, which is transmitted to the individual by the family or friends; objective fear, due to one's own experience and direct stimulation of sense organs. So development of fear at birth, the primary response occurred soon after birth, such as startle responses at birth. And with age, he becomes aware of the fear-producing stimuli and can adjust to the experience by resorting to the flight if he cannot solve the problem. In preschoolers, the fear of animals or being left alone, abandoned is the main fear, or separation anxiety is the main fear. And they will be more apprehensive about failures. Early schoolers, fear of the dark, staying alone, shows fear of supernatural powers. These are all the fears. In late schoolers, by age of 9, fear of bodily injury may be present, fear of failure, not being liked, competition, fear of punishment. These all can be there in a late schooler. In adolescence, fear of social rejection and fear of performance can also are the fears that can happen. So the answer to this question, without stimuli or previous experience, is actually innate fear. So while performing pulpotomy in children, if the operator uses formocrystal for short duration, it will be an example of devitalization pulpotomy, preservation, regeneration, reparative. So this is again the based on the classification of pulpotomy. We have already discussed one question based on the classification. Another question has been asked on the same topic. When formocrystal is used, it comes under devitalization pulpotomy. So formocrystal comes under mummification or devitalization pulpotomy. The histological changes that happens after placing a formocrystal was demonstrated by Maas and Sieberman in 1933 and also by Masler and Mansokhani in 1959. Immediately, what happens is the pulp will become fibrous and acidophilic. In 7 to 14 days, 3 zones will appear: a broad eosinophilic zone of fixation, broad pale staining zone of atrophy with poor cellular definition, a broad zone of inflammation extending apically into normal pulp tissue. And in 1 year, there will be progressive apical movement of these zones with only acidophilic zone left at the end of 1 year. So these are all the histological changes that can happen after formocrystal placement. So the next question, the last question for discussion today is, a newborn infant will turn his head towards anything that strokes his or her cheek or mouth, searching for the object by moving his head in a steadily decreasing arc until the object is found. And this is called reflex, rooting reflex, neck writing reflex, Galen reflex. So the answer will be rooting reflex. So there are many neonatal reflexes you should study about to answer this question. So these are all the neonatal reflexes that are present. So rooting reflex is when we gently stroke the infant from the lips to cheek, and the normal response of the infant is to turn his head towards the stimulated side with the mouth opening. Then comes the Moro reflex, which is given in the option. Moro reflex is actually stimulated by a sudden movement or loud noise, and the neonate will be respond by throwing out the arms and legs and then pulling them towards the body. Next, rooting reflex is the correct option. Then Gallant and neck writing reflex. Gallant reflex is actually when the neonate back is stimulated, the trunk and hips should move towards the side of the stimulus. And asymmetric tonic neck reflex is when we gently turn the infant's head to one side, flexion is torn is on the side and opposite to the head turn, with an increase in the upper extremity extensor torn the side to which the head is turned. So we have to study about the neonatal reflexes to answer the previous question. So we have rooting reflex, Moro reflex, suckling reflex, Palmer reflex, Babinski reflex, asymmetric tonic neck reflex, tonic labyrinthine reflex, Gallant reflex, and Landos reflex. So these are all the neonatal reflexes that is present in the child. So that marks the end of our session. So as I told, focus on the topics from which more questions have been asked, like pulpotomy, fluoride, spit and fissure sealants, oral habits, then stainless steel counts, the complications, etc. So try to cover all the topics which has been mentioned in the session, and I hope this actually made you learn something about periodontics. So happy learning and all the best for your exams. Thank you.